might need the Jeopardy music. Peter, maybe on the break you could work on some Jeopardy music for us so we don't all sit here. Okay? And again, as things come to you, even though we're focusing on this right now, you know, if you're like me, sometimes things come up to you 20 minutes later. I'm like, oh yeah, I should have wrote that. So just keep making this a fluid and working document throughout the day, okay? Okay. People are still writing, which is good. I'm going to give you another 30 seconds. Those must have been some lofty goals. Great. Okay. So while you keep writing down, I would like to bring up Dr. Ariel Waters. She is our Public Health Program Administrator at the Department of Health, the Office of Health Equity, and she's going to introduce our keynote speaker. And as David pointed out earlier, she was the point person who helped pull this all together, and you did a fabulous job. So thank you. I know it was a big job. Thank you. Please welcome Ariel.
Good morning, everyone. Thank you so much for being here as well. And huge thanks to our keynote speaker who's traveled through snow and wind and rain to get here to be with us today. So thank you. Before receiving his PhD from Harvard University, Dr. Kaplan attained his joint master's degree in public affairs and regional planning at Princeton University, right across the river. Gabriel Kaplan is the chief of the Health Promotion and Chronic Disease Prevention Branch in the Prevention Services Division at the Colorado Department of Public Health and Environment. In his role, Dr. Kaplan directs and manages work units that seek to improve policies around health promotion and prevention, to transform the delivery of care within health systems, and to improve the linkages between community-based prevention and the clinical care system. Prior to this, he served as the Director of Epidemiology, Planning and Evaluation Branch in the same division, where he directed the data analysis and research units that supported public health prevention services and interventions. Before joining the Colorado Department of Public Health and Environment, Dr. Kaplan served as the Assistant Professor of Public Policy at the University of Colorado, Denver's School of Public Affairs. He also serves as an Adjunct Assistant Professor at the Colorado School of Public Health. Dr. Kaplan has been a board member of the National Association of Chronic Disease Directors, and he recently ended his term as the president of the board and now serves as past president. If you could all please give me a hand and welcome Dr. Gabriel Kaplan.
Okay, great. Wonderful. Thank you so much, Ariel. It's a pleasure to be here. And I want to first mention that I began my career in health policy 29 years ago working for a gentleman from this state, Harris Wofford, who was senator at the time. And Harris was a leader in the civil rights movement. He was one of the founding fathers of the Peace Corps, and he was I think he was the first leader of the National Corporation for Public Service, and was a real proponent of national service for young people in America. And so I would be remiss, especially at a health equity conference, if I didn't mention Harris and the profound impact he's had on me, and I think the profound impact he's had on this country. So it's a pleasure to be here. I'm very humbled and honored to be here. And I have to say at the beginning, I recognize the irregularity of my being here. I'm a white man from Colorado, and it's not every day that a person like me comes and speaks to a large audience about health equity. And I'm uncomfortable by the appearance that I might be lecturing the people in this room who know far more about equity issues than I'll ever experience or know in my life. But I have, over the last year, had the opportunity to lead the National Association of Chronic Disease Directors, and I set as my president's challenge the need for us to move our programming upstream. We spend a lot of time in chronic disease prevention doing health management, disease management, and we really need to sort of move further upstream and help programs figure out ways that they can get involved in addressing these problems before they develop and create greater equity across our society. I've learned a tremendous amount doing this, and I'm really grateful to share with you today some of what I've learned. So my President's challenge, as I said, is sort of trying to move the field of public health, particularly chronic disease prevention managers, from understanding that social determinants of health matter and understanding what social determinants of health are to knowing what to do about them. And so I've had an opportunity to speak with people across the country, and I'd like to share with you today some of what I've learned. What I'd like to do to begin, though, is really discuss this notion of social determinants of health and how place and issues from our past, some very negative, affect health and health inequities today. And then I'd like to move to how we can use public health tools to break these problems apart and identify strategies for solution, and then share with you some of the strategies that folks from across the country have been using to try to address some of these problems. So I'd like to begin with a slightly different representation of the factors that affect health status from the representation David showed in his presentation. This is from McGinnis and Fagey. Bill Fagey is one of leaders in CDC in our understanding that healthcare only drives a small percentage of health status across the lifespan, and that other factors matter a great deal. The environment accounts for 20% by his estimation, and lifestyle for over 50%. But what this chart really begs is the question of what's involved in that environmental piece of the pie. Are we talking about just the physical environment and things like pollution, or are we talking about social and economic factors as well? And where do these behaviors, these lifestyle choices that people make come from? This chart doesn't really say much about that. So let's spend a little time thinking about some of the factors that drive these relationships in America. Let's begin with spending on healthcare. It's something that's on the front of everybody's mind with the political campaign. It's been an issue in American politics going back to my experience with Harris when he made national healthcare one of the planks of his election campaign in 1991 and really put the issue on the map for people. And so what we know about America is we spend more on healthcare, far more on healthcare than any other nation. And particularly any other Western developed nation, Western industrialized nation. You can see that in many cases we spend over twice per person on healthcare what other countries spend, and we get far less for it. Our life expectancies are far lower than those other nations. And so something is going on that we're missing in our current approach to health in this country, and it's something that we need to think about and address. So another way to think about this data is shown here. And you can see with the brown bars, which represent healthcare spending, that the US is an outlier in terms of how much we spend on healthcare. But you can also see that we're an outlier because of how little we spend from our economy on social services. And then one thing that Americans like to pride themselves on is small government, right? But what you can see from this chart is that we're really not that thrifty. What differs in our approach to healthcare and social services is the distribution and where we choose to spend our money. And Elizabeth Bradley from Yale University has pointed out that nations which invest in social services, things like the safety net, education, transportation protection, they have much longer life expectancies than countries that don't. So this is something that we need to think about. Another thing that we need to think about is the growing levels of income inequality in this country. This sets us apart from many nations, particularly the Western industrialized nations. Here you can see how economic gains have been distributed across society since economic recoveries since the Second World War. And what you can see is the growing inequality across American life. And particularly after 1980, you can see that as the economy would recover from a recession, more and more of the economic gains would be distributed to the top 10% of the income distribution. And in fact, from the most recent recession, For the four or 5 years after that recession, it was such a deep and severe recession, the bottom 90% of the income distribution, that's 90% of the population of this country, continued to lose economic ground. So even as the economy was expanding, 90% of the people in this country were getting poorer, and only 10% of the people were getting wealthier. So it's often noted that America is a very diverse country, and we're more diverse than many of our Western industrialized counterparts. But what is often forgotten is that we are also, despite the fact that we are a diverse nation, we are also a highly segregated nation. What this slide shows here is the segregation data from South Africa in 1991. This is under de jure legal apartheid. And then it compares the same data from the year 2000 for American cities and the levels of segregation, a segregation index, where 100% is complete segregation. So you can see across Detroit, Milwaukee, New York, Chicago, Newark, Cleveland, and then the rest of the US, incredibly high levels of segregation. And this is many decades after Brown versus the Board of Education. So what we know now, increasingly, is that place matters, and that segregation levels end up mattering a great deal when we compare the kinds of neighborhoods and communities that different populations live in. We know and have come to appreciate how place matters in shaping health. It's easier to stay healthy in the communities that look like those on the left side of this slide than it is on the slides, than the communities on the right. And we have to ask ourselves, why do certain neighborhoods look like this? And what impacts does this have on the health of the people who grow up and live in those neighborhoods? So here's a map from over a decade ago that was drawn by Dr. Anthony Eiton and his team at the Alameda County Public Health Department. They were some of the first people in public health to show how place impacts health, and we owe so much to his path-breaking leadership and imagination in this area. What we have is a map of life expectancy on the left and a map of Alameda County poverty levels on the right. This is drawn by census tract, and the intensity of the shadings shows the level of the problem. So what you can see on the left is that the lowest level of life expectancy shown in the color red, those census tracts are highlighted there. And on the right, you can see in the shades of beige, brown, you can see the intensity of poverty. And you can see a very strong correspondence between the areas of yellow on the left and the areas of yellow on the right, the areas of brown on the right and the areas of red on the left. And what Dr. Eiton discovered is that where you lived in Alameda County could account for up to 15 years of difference in life expectancy. So people on the eastern parts of that county were outliving their peers in the Bay Area by up to 15 years. Here's a similar map from the city of Pittsburgh. I pulled this from the Allegheny County website, and I had to draw the yellow pretty roughly with my pen on the computer to show you the outlines of the city of Pittsburgh. We have life expectancy on the left, and we have per capita income on the right. And the darker shades of blue represent lower levels of income, income between $2,000 to $21,000 per capita, and life expectancies that are in the 70s and 60s with darker shades of blue. And what you can see is a very similar pattern to what you saw in Alameda County. Those areas that have the darker shades of blue correspond both in life expectancy and in per capita income. Here's the same picture, essentially, for the city of Philadelphia, life expectancy on the left, percent of poverty on the right. Again, the darker shades of blue representing lower levels of life expectancy, higher levels of poverty. And you can see, this is census tracts, very strong similarities in terms of the neighborhoods that show up with those darkest shades of blue. Here, lest you think that it's just reserved for Philadelphia and Pittsburgh, this is a map of Allentown, same thing, life expectancy on the left, percent of poverty. This is percent of children in poverty on the right, with the same shading symbols, and again, you can see that very strong level of correspondence. The same neighborhoods that have low levels of life expectancy have lots of kids in poverty in them. So what we need to understand is that these patterns are not random. They're not an accident, and they're not a function of where people choose to live. They are a direct outcome of policy decisions from our past. On the lower left here, we have a snippet of a form from the Home Ownership Loan Corporation, which was a predecessor of Fannie Mae and Freddie Mac. This was created in the 1930s during the recovery under Roosevelt. It's a program that was intended to sort of shore up the housing market, a lot of the savings and loans. That's sort of what's featured in the movie It's a Wonderful Life. Collapsed because of the banking crisis associated with the Great Depression. So the federal government stepped in, but they wanted to reassure voters that they weren't going to lend money to risky neighborhoods and risky populations. And they assessed, as you can see, the riskiness of a population by whether people of color lived in those neighborhoods, whether immigrants lived in those neighborhoods, what the education level was. And they created these maps, redlining maps, and they're called red because of the shade of red. And red indicated a very high level of risk. This said to lenders, don't make loans in this area. This is a very dangerous neighborhood. Yellow were transitional neighborhoods. Those were pretty risky too. Green and blue, that was safe. And so people in those districts couldn't get loans. And the impact that this had on the communities was profound. It's particularly important to understand the impact this had on the black middle class. Up until that point, despite all of the oppression that existed in American society, all the segregation and legacies from slavery that existed, there was a thriving black middle class in many parts of urban America, and they owned land. But that land became worthless because they could not sell that land, they could not sell those homes to anybody because those people could not get loans to buy it. And this wiped out lots of wealth, in America among black middle class families. And this pattern was not reserved to the biggest cities in America. Here is the same map for the city of Pittsburgh. And I want you to pay attention to the areas of red in these maps that I'm about to show you because they correspond to those maps I showed you earlier on low levels of life expectancy. The same parts of the city that were redlined in the 1930s are the areas that show up today with the lowest levels of life expectancy and the greatest levels of poverty. Here's Harrisburg, Pennsylvania. You can see the redlined areas here. Here is the city of Bethlehem, again with areas of redlining shown here. And here is the city of Wilkes-Barre. And again, I'm going to show you more disease maps later in this presentation, and remember these neighborhoods that were shaded red, because they're going to be the same neighborhoods that show up with high levels of diabetes, obesity, smoking prevalence. And I think it's really important to understand and underscore this point. And let's just go back to this for a second. If you didn't have public health data on these cities, you'd be okay, because you could just look up these redlining maps that were drawn in the 1930s, and you could say, what neighborhoods were redlined? Those are the neighborhoods where I need to focus my health equity efforts. And that's really just a startling fact, that you don't need public health data to know where to work. You just need policy data from the 1930s. And I think it's important to understand that these phenomena in American life are not just isolated to poor communities or city regions where there are high concentrations of people of color. All of us are impacted by the design of American life. And poor health is woven into the fabric of that life. It's woven into the distribution of suburbs and cities, the fact that we have to drive everywhere, the fact that we don't have time and that we're stressed and we have to eat fast food and processed food and high levels of carbohydrates, and that poor families have to buy lots of sugar. This is embedded in the fabric of American life, and it affects all of us. Americans are sicker across the board than their counterparts in Western industrialized nations. Industrialized Western nations are shown up here. There's a number of different ones, and you can see that in every single chart in every disease area, whether we're talking about lung disease or obesity or smoking or diabetes, American rates of disease are much higher than these Western European industrialized nations. And again, everyone is harmed by this. No group in America escapes from this reality. What you have here is a map of chronic disease prevalence in a number of different areas comparing the United States to England. And the United States is shown in blue, England is shown in orange. It's across a number of different disease areas. But what I've done in this is I've only shown you the highest income groups from both nations. So we've pulled out all of the lower income groups. This is the top third of the income distribution. And you can see that the top third of the income distribution in the United Kingdom, even though the United Kingdom per cap, in terms of per capita income, has a lower level of per capita income than the United States, that they're much healthier than we are. The only difference is in smoking because of the higher rates of smoking in the UK compared to the US. But in every other area, the US is almost twice the level of chronic disease, twice the level of diabetes, twice the level of heart disease, much more cancer than the United Kingdom. And if I drew this map for those with the highest levels of education and it took income out, it would look exactly the same. In fact, I did draw the map, I just didn't want to show it to you. But it's exactly the same picture. So this is your education doesn't protect you in America from getting sick. And your income doesn't protect you from being sicker than people in other countries. So all of this points to the fact that the future of public health is now. And so we in the public health community have come up with this concept of public health 3.0, which borrows from the IT community. And what does public health 3.0 mean? So I think about it in the following way. Public health 1.0 is traditional old-line public health. It's infection control through treatment, isolating people with infectious disease like tuberculosis, addressing that, giving prophylactic medication to people with HIV, for instance. It's clinical preventive measures like immunizations. Public Health 2.0 represents our efforts to move into policy and environmental change. This began in the 1950s and 60s when we discovered smoking caused lung cancer. It represents, our auto safety efforts were another example of this. And then we began to do systems building work like developing the diabetes prevention program. So this was sort of focusing on the things that really make a difference in whether or not people get sick or healthy, trying to make the healthy choice the default and the easy choice. But we know that that in and of itself is not going to be enough. So Public Health 3.0 represents our efforts to move into the social determinants of health, to address issues like food, housing, transportation problems, and limitations. And it requires that we forge partnerships with a variety of agencies and departments at the federal, state, and local level. Departments of Education, Human Services, Transportation, Housing, and Revenue. Here's a visual representation. I like imagery a lot, and so I'd like to show you visual representation of Public Health 1.0. This is Dr. John Snow on the right. This is the map he drew of the cholera epidemic in London. You can see in the middle of this map the Lambeth Well, or the Broad Street Pump as it was called. And what Dr. Snow identified was that where you lived in proximity to that pump determined your likelihood of getting cholera. And so he hypothesized that the pump was the source of the disease. He took the handle off the pump and then protected the pump with some soldiers, and that solved the cholera epidemic. And so Dr. Snow used public health strategies, not nurses, doctors, to save lives in London. And this really became our model of Public Health 1.0. Here's a model of Public Health 2.0. It represents the idea that if we address healthcare equity in the medical, clinical setting, if we provide educational resources to people so they understand that eating sugar is bad for them, that smoking is bad for them, if we give them opportunities for physical activity, and if we provide them with healthy food options, then through their agency and biology, they will not become obese, they will not smoke, and this will result in fewer diabetes, fewer cancers, cardiovascular disease, and so on. And then, of course, the environment is shown with pollution on the left and its relationship to other chronic diseases. I'm focusing on chronic disease in this presentation because that's what I do. I manage chronic disease programs. But if we looked at infectious disease, it would be the same thing. If we looked at other conditions, many of these patterns would be the same. And what you can see is this really focuses at the micro level and on the individual, and it really forgets that broader environment in which individuals are embedded. So we need a richer approach. So I'd like to have you indulge me for a moment. I sort of drew this myself. I want to show you my metaphor of how I understand Public Health 3.0. This is a cartoon from a newspaper in London during the cholera epidemic in the 1850s. You can see the Broad Street Pump. You can see Death dispensing her horrible elixir to the children and mothers of that community. And what I want to show you is what's below the pump today. So what we need to understand, and what we need policymakers to understand, and our neighbors and our friends and our community members to understand, is that we are all drinking from a poisoned well. And that well is filled with segregation, sexism, racism, income inequality, redlining, low funding for education, particularly in certain communities, food insecurity, crime, poverty, mass incarceration, violence. And this affects all of us. We are all drinking from this well. And if we focused in Public Health 1.0 on environmental hygiene, today we need to focus on what we might think of as social and economic hygiene. How can we make the argument that addressing these factors is a critical component of public health work, it's a critical component of our allies in the healthcare setting, and a critical component of our allies across state agencies, community nonprofit organizations, and the federal government. So I'd like to take chronic disease and map it into a systems dynamic map that looks at the root causes that we've discussed so far. So we'll start with this map I showed you previously. I've taken out some of the factors because I'm going to want to reconstruct these from the beginning. And I want to start with the levels of differentiation in American society. We're differentiated on the basis of race, ethnicity, sexual orientation, gender, class, income, and ability, a variety of different things. And these give rise to the isms. Now, they don't cause the isms, but our reaction, our human reaction to this has led to the isms. And these isms directly shape the kinds of policies that emerge from our political dialogue in our society. And these policies, over time, have resulted in things like segregation, disenfranchisement, the alienation of communities and populations and individuals. And all of these factors together reduce civic participation and political power. And once you have low levels of civic participation and power, particularly at the community level, you have low levels of investment and economic opportunity. You have inequitable and low-performing education systems. You have sources of stress because the social safety net isn't adequate to provide food security, income, housing, and high levels of crime. And then you have crumbling infrastructure, and finally, low levels of social connectedness. And these things lead to health systems inequity. They lead to unjust food systems, inequitable activity options across the society, psychosocial stress, adverse childhood experiences. And these things filter through individual agency and biology to affect obesity, tobacco use, substance use like alcohol, opioids, mental health problems that lead to substance abuse, trauma, et cetera. And these result in our high levels of diabetes. And it explains the differentiation in these levels across communities. So not only do we have to think about the micro level, we have to think about the macro level, and we have to think about the meso level as well. We have to think about where this comes from at a broad level of government, communities, states, and nations, how this is shaped and manifests in neighborhoods and communities and social networks, and then also how this shows up at the individual level. You can see these same processes in the Barhigh model shown here. This was developed by Anthony Eiton again and his colleagues at the Bay Area Regional Health Initiative. And it shows traditional public health practice on the right, and it uses graphics to show the additional levels of social, political, and economic forces that act on health outcomes and mortality. This area on the left that is circled represents the emerging practices of Public Health 3.0. And by now, I think many people in public health and in healthcare get these relationships and the need to work on them, but they're still wanting instruction on how to do this work. And they're looking for examples. And so this is really what my President's Challenge has been about, and I want to talk to you about what I learned over the last year, talking to people like Dr. Eiton across the country, and share with you some steps, 10 steps that we can all follow to do this work effectively. So step number one is to build Public Health 3.0 on public health principles. Don't stop what you're doing, add to it. What do I mean by that? Well, Public Health 3.0 uses that IT language for a reason. If you think about your Windows operating system, I'm fortunate that my state decided we needed to upgrade to Windows 10, I think a year ago. I think it's been out on the market for about 5 years. But you know, Windows 10 has Windows 8, it has Windows 95, it has Windows 3.1 embedded in it. And by the same token, we need to continue doing Public Health 1.0. We can't stop. We need to continue thinking about Public Health 2.0. We need to add on Public Health 3.0 on top of it. We don't want to reinvent the wheel, we want to learn from others. There are a lot of people, particularly in my state, we have this temptation to think, well, Colorado's different. We don't need to look at what's going on in other states, and we absolutely do, because everyone across the country is struggling with these issues. We need to listen and learn from each other. And we want to use our training. We want to think about the evidence-based framework. We want to collect data. We want to talk to the community. We want to assess the science and the literature. We want to do evaluation. And we want to engage others through partnership. I think it's really important as we start to engage in partnerships. I know there's a representative from the Department of Education, Department of Transportation here. We have to approach these sectors with humility. We can't, as public health, say, we know what's wrong in this sector, and we're going to tell you how to do it. They know what's wrong in that sector far better than public health does. They've been working in this area for decades. What we need to do is say, we have some resources. We understand that health is related to education. How can we help you? How can we help achieve our common goals to improve the education of the populations that pass through the education system and improve the health outcomes of the people who come through that system? Because we know that education gives you health in two ways. It provides economic security and opportunity to you, and it provides you with a level of ability to navigate a very complex system. So education is critical. Step number 2 is we want to think about that model of chronic disease I laid out, and it shows that we need to work along 3 levels: policy and systems change, particularly focus on food, income, and housing security, community-based geographic environmental change, and interpersonal relationships. So our challenge is to develop strategies that work at the micro, meso, and macro level. Because people are living, everyone, in a sea of stress, inequity. They're experiencing factors that are not conducive to health. And no one strategy is going to be enough to reverse this. We can build bicycle paths for everyone, but if people are living in bad housing and if they have food insecurity, it's not going to solve their problems. These problems are socially constructed from so many different factors, we have to think about all of them at the same time. So what we want to do to reverse this is deconstruct the policies of oppression. We want to reconstruct neighborhoods and communities, and we want to co-construct systems that let everyone achieve health. Now, this should be familiar to us in public health because this is the social ecological model that we learn in school. We want to think about things at the individual level, the interpersonal level, the organizational level, community, and the government level. This is not necessarily new work. This is a new approach to some of the same work we've been doing. Step 3 is to think about that macro level first. We want to speak truth to power. We have to speak truth to power. We have to show folks that there's scientific evidence that links the root causes of disease, the social determinants, inequitable policies, to poor health outcomes and premature death. We must communicate this evidence to policymakers. So we want to engage our audiences with a call to action, and we want to commit to communication. And luckily, as public health, we're prepared for this because we have a model, the Stages of Change model, which shows how people can change. And we want to move people from pre-contemplation to action, and we want to prevent relapse. We have to understand that policymakers are an audience that doesn't know that they have a problem, that we have a problem, and that there is a problem. So let's take a look at some maps. I drew these using the 500 Cities project, and want to show that the idea that in the U.S. where you live shouldn't determine how healthy you are, that's an idea that cuts across partisan lines, it cuts across ideologies. People, regardless of their voting affiliation, resonate with this idea that where you live shouldn't shape where, the health that you have. So let's take a look at these maps. Philadelphia, you have obesity on the left, smoking on the right. Again, the areas of darker blue show the greater intensity. Here's Bethlehem, diabetes on the left, regular dental visits on the right. Areas of darker blue, again, show higher levels of prevalence of the disease. Pittsburgh, diabetes on the left, high blood pressure on the right. Again, the same census tracts that had high intensity of both these conditions show up here. Here's Scranton. We have children in poverty on the left, mental health distress on the right. Again, very strong similarities, slightly different shadings, but the same census tracts show up in both. Here's Erie, for those of you from Erie who made the trip. Smoking on the left, physical inactivity on the right. You have to really stare at this map for a while to sort of understand, are these different maps or is this the same map? And here's Reading. high blood pressure on the left, obesity on the right. So drawing these maps is possible. You can go to the 500 Cities Project website for these, for a variety of different examples of this. And you can work with your GIS staff if you have them in your health department to draw these maps. It's going to be harder in rural areas to get data at this level of granularity, but it is possible, and you can also collect it, on your own with foot and sort of shade these maps to figure out where you need to target your efforts and what communities you need to focus on. So step 4 is to begin with data and metrics. Identify a clear set of social and economic metrics and connect those metrics to your health outcomes. And then build public-facing dashboards that track your metrics and show your progress and show the relationship between metrics like the housing cost and graduation rates and their relationship to health. And make that public-facing. And if you're looking for where to find this, you can go to various places. The Healthy People 2020 framework has a whole section on the social determinants of health. They broke it into 5 domains: economic stability, education, health and healthcare, neighborhoods in the built environment, and the social and community context. And within each of those hyperlinks is a set of indicators that you can collect data on, and you can find data from a variety of sources. Here's an example from the state of Rhode Island. They built, as part of their project to create health equity zones, a dashboard. They've identified 5 domains where they want to do their work. They've identified social determinants, 3 of them in each of these domains. And then they've identified an indicator that they're going to track. This is where they're going to focus their work and hold themselves accountable. And then the understanding in the theory of change is that by moving the needle on these factors, all of these factors, and seeing progress along that continuum, they're going to improve the health outcomes in these communities. Step 5, as David said, we need to institutionalize our commitment to equity. A great step for that is a statutory office dedicated to health equity, and help people understand that inequity is more than just disparities. It's built into the structure of life, and it's inescapable for many people. And as I pointed out, it's really inescapable for all of us. And we need to get creative. We need to push the boundaries of public health work. What do I mean by that? Well, in Colorado, we are fortunate to have an Office of Health Equity. It was established in statute as the Office of Health Disparities in 2005. We renamed it in 2013 as the Office of Health Equity. That was renamed in statute. And they serve a variety of purposes, not just to assist folks in the public health department, but folks across all state agencies to understand inequities in American life and what needs to be done about them to improve the health of our communities. And they developed a grant program. They give about $3.5 million of tobacco tax money out. And for many years, they distributed that money to focus on chronic diseases like cancer, asthma, diabetes, hypertension, and they were focused on secondary and tertiary prevention. And what they're doing now is giving grants to do neighborhood relationship groups between communities and the police. They're doing grants for reentry for individuals from the institutionalized justice system back into the community. They're focusing directly on that social determinants of health work, and then showing their accountability for those health metrics in regular reporting to the Board of Health on the relationship between the work they've done and how it's improved health. Step 6 is really critical. It's at the meso level. We need to seek direction from the community. We cannot show up as public health experts and say, here's what you need. You need a grocery store in your neighborhood, or we're going to build you a footpath. Social determinants are about places, they're about networks, they're about experiences, and so you have to put the people from those neighborhoods who live in those places and have had those experiences at the forefront of your movement, and they must lead, and you must function as a servant leader. Political power correlates with premature death and disease more than risky behaviors, and a lack of voice is the first determinant of health. That's a very important thing to understand. Charles Brown, who I think is going to join us later today, he's an urban planner from Rutgers. There he is, on the back of the room. He argues that we need to call the social determinants of health the political determinants of health. And I think he's really onto something here. And inspired by his example, I drew these maps. On the left, you have obesity, and on the right, you have voter turnout. Voter turnout is shown, low levels of voter turnout, again, by darker blue, and high levels of obesity, again, by darker blue. The map on the right was GIS, so it gave me yellow for high voter turnout, but you can see the correspondence. Same neighborhoods that have low voter turnout have higher levels of obesity. Here's smoking in Pittsburgh and voter turnout in Pittsburgh. Same neighborhoods that have high levels of smoking, low voter turnout. And I wanted to draw a map so I wasn't just Philadelphia and Pennsylvania and Pittsburgh centric. On Allentown, I didn't have the facility to do one, so I had to pull an existing map from GIS. On the right, it flipped the color scheme. So on the map on the right, low voter turnout is shown in yellow. And on the left, again, obesity is shown with high prevalence in navy blue. And again, you can see the correspondence. Those parts of the inner city in Allentown that have low voter turnout have the highest levels of obesity. Step 7 is to ask yourself and ask your colleagues, is your own house in order? You can't approach communities in distress without work populations that resemble the communities that you're trying to work in. In order to build trust, we have to practice diversity in hiring. We have to build cultural competence when we can't effectively hire diverse workforces, and we have to lead with humility. We have to understand that everyone is responsible and no one is to blame. This is really important, I think, in health equity work because people are growing up in a sea and have lived in a society with great inequity and discrimination for many years, and they've internalized that. A lot of us have internalized this, and it comes out in language, and they'll stumble. They'll commit microaggressions. And we have to be ready to deal with that, and we have to be ready to have honest conversations, forgiving conversations, in order to educate each other and elevate our discussion and our practice. And we need to remember that we have to approach communities with multiple options so that we're not in the role of dictating to them what they need to do. That's why if you're working in chronic disease like I am, and you want to do obesity work or diabetes management work or hypertension work, and your dollars are required to be in those areas, go to your injury prevention folks and say, do you have injury prevention money, substance abuse money, behavioral health money that I can pair with you? We can go into that community and we can ask them, where do you want to focus? Maybe the community wants to begin with the opioid crisis. Or maybe they want to begin with obesity, but they don't want to build a grocery store. They want lighting on the street so people can walk at night. Let the community tell you what to do and follow their lead. So step 8 is get creative with financing. The money is there. We spend $3.5 trillion in America on healthcare. $3.5 trillion. It's not whether the money's there, it's how we spend our money. 97% of the healthcare dollars in America are spent on treating acute disease, and only 3% are spent on prevention. We need to pool our resources that exist, we need to braid our funding, and we need to cut strings. The variety of ways we can do this. There's the community benefit in the ACA, which requires nonprofit hospitals to take dollars that used to be used for charity care and invest them directly in the community. Nobody to date at the state level has used that to really require hospitals to make investments in communities that are distressed. We can use the certificate of need process. Massachusetts has done that. We can use investments in prevention. We can use payment reform. We can use things like the Preventive Services Block Grant. And we can ask other partners to contribute what they can afford. Len Nichols at George Mason University has developed a really fantastic model in partnership with Elizabeth Bradley and Lauren Taylor that allows health systems in a community to pool their resources and share information to make investments in communities in places that most need it. So examples, Rhode Island and Colorado braided their funding in the way I described so that multiple pools of resources are available to a community and the community can select where they want to work. Michigan used the Preventive Services Block Grant. They moved everything that had been on there off of it and just used it for adverse childhood experiences. Massachusetts uses the Certificate of Need process. There's a community benefit under the ACA. And North Carolina just got permission from CMS to use their Medicaid program to pay for things like rent, for food, for transportation, a variety of things that are not medical. But they're going to do this as a pilot, and they're going to see what the impact is on Medicaid costs and on the health outcomes. Finally, at the micro level, don't just medicalize the problem. The healthcare system has discovered the social determinants of health, and they're engaged in a variety of efforts to integrate referrals for social services into EHRs. But this is not enough. On the one hand, the health system could potentially overwhelm community-based organizations by referring people to food banks and housing organizations, and just there aren't the resources there to deal with the magnitude of those referrals. And then secondly, we have to understand that operating at the individual level is not enough. People are living with bad policies. They're living in communities that are crumbling. We have to address those things as well. So step 10 is to remember and share and communicate and be guided by this principle. And it's that if we do this work, and we do this work well, everybody wins. All of us are swimming in a sea of stress, conflict, adversity, inequity, and it makes all of us sick, and it ends all of our lives prematurely. By transforming the social and political realm and moving towards greater equity, we will help everyone. Racial justice work is not work done for people of color. Systems that fail people of color, communities of color, they fail all of us. And public health institutions are critical to play a role in dismantling these long-standing systems of oppression. A rising tide lifts all boats. We need to share that, we need to understand that, and I think if we can do this, we can begin to heal the great divide that exists in this country and the horrible hostility and conflict that exists across party lines, across racial and ethnic identities. We need to understand that everyone is victimized by our inequity. The suspicion that drives a focus on safety net programs that exists in many low-income white communities, they would benefit those communities. Jesse Jackson used to say, most people in America who are on welfare are white. Most people in America who are on Medicaid are white. People who have a hostility to government spending are hurting huge numbers of poor, low-income, low-educated white people in this country. Everyone suffers because of this framework of inequity and racism that we live under. So health equity work is crucial. It's work that we all need to engage in, and it's work that's going to benefit everyone across the board in this country. Thank you so much. Did you want questions?
Yeah, stick around,
Okay.
stick around. All right, thank you so much, Dr. Kaplan. That was wonderful. I noticed a few people writing some questions down, so I want to take a few minutes. If you have a question, can you raise it? We'd like to get our staff to collect those. If anyone has a question they'd like to ask Dr. Kaplan now. Anyone? Yes? You sure, just grab it there and you, okay, you want to come up and read the, okay. All righty, let's see. Come on up here with me. All right, it says the maps show a correlation between life expectancy and income. What's that? Learn from
Learn from these areas.
Learn from these areas.
But there were some low income and had higher life expectancy. What have we learned from these? So there's not a 100% correspondence between income and life expectancy, between income and obesity, between smoking and obesity. There certainly were some differences. There were some pretty stark differences I realized in Philadelphia, and I was wondering about that, and I looked at the map, and I think that that's the University of Pennsylvania, is that neighborhood in Philadelphia that had pretty high levels of poverty, but much lower levels of smoking and obesity. And I think it's sort of that intermixing of the poverty and younger, highly educated populations. So there are a variety of things that account for this. You know, when we're talking about correlations, we're not talking about a 100% correlation. If we did a regression analysis or we did a correlation score in statistics and we found an 80% correlation, that's a tremendously high level of correlation. 50% is a pretty high level of correlation. And a lot of people publish dissertations with a 30% correlation. So I think it's not a 100% correlation, but it's a really significant correlation. And I think when you find those differences that don't really match up, you need to sort of drill down and start asking the community why those differences might exist. And it might be because there's a university there, or there's some other factor that you're just not aware of.
Okay, we have another question here. It says, it seems that many do not care about addressing inequities because helping the poor might not benefit someone who is wealthy, who is healthy or wealthy. So what are some economic and or social benefits that it is wealthier, that the wealthier see when health disparities are addressed? This is in a global or a local context.
So I think one of the things that's important here is to understand there's sort of two sides to government programs. There's the side that pulls the resources, and then there's the side that distributes the resources. And Social Security is an example of a really equitable program because it gives the same sort of benefit to everyone, regardless essentially of what they've paid in over their life, and really does a great deal to redress inequities. And what we try to do is collect the resources on the front end in an equitable manner. And so I think programs that are seen as being beneficial to everyone are going to be much more politically popular, but they're going to be much more crucial to people who are sort of on the lower end of the economic spectrum. If you think about things like the debate around the minimum basic income, Andrew Yang in the presidential campaign is talking about that. You know, they're not talking about giving out huge amounts of money, $500 to $1,000 per person per month, perhaps, which isn't going to make a lot of difference to wealthy people, but is going to make a huge amount of difference to people at the lower level of the income distribution. So I think focusing on those sort of universalistic programs is an important component. And then I think also getting people to understand these relationships that even if you're wealthy, if you're highly educated and you live in a particular community, you can't build walls high enough to protect yourself from the impacts of living in American life. You're still going to be eating Doritos, drinking soda, sitting in your car. So those impacts are going to affect all of us, and I think there's a lot of equity work, health work that's going to benefit everybody that's not going to be seen as just being done for one group.
Thank you. We have one final question, and that is, any thoughts on how communities can avoid another Flint, Michigan?
That's a great question. I think what's really important in the understanding the example of Flint is the level of fear that the policymakers operated under. After they discovered there was a problem, they buried the problem, didn't want anybody to know about it. And then the second thing was they didn't listen to the community, and they didn't put the community in a position of leadership, and they weren't acting as servant leaders. So I think the most important thing that we in government can do is to remember that we are servant leaders. We are not at the front, we are at the back. I was early in my career, and an older gentleman said to me that his understanding of leadership was, there go my people, I must hurry up and catch up to them because they are in the lead. And so I think that really is what's going to be essential to us. Obviously, resources matter. What happened in Flint, Michigan was a result of low levels of resource. It was a result of Flint trying to find alternatives that were cheaper because of their financing problems. That's a result as well of the inequities that exist in how we finance local operations in America. So it's another example of a macro, meso, and micro problem. You know, there were problems in the micro level in the houses that were more prone to dispense lead out of the water. There's a meso problem in terms of the infrastructure in Flint, Michigan. And there was a macro problem in the design of how local finance and government exists.
Great. Thank you so much. Thank you, Dr. Kaplan. Did you? Yes.
One comment.
I don't mean to interrupt, but your comment about social determinants versus political determinants. Social determinants should be political determinants, and the correlation with voter turnout. And I can't let this go today. Yesterday in Pennsylvania, I'm a member of the State House. The governor signed a bill for major voter reform, the first major reform in 82 years. So all of these people in this room today who have all these constituencies need to learn what opportunity that presents, because I have made that case and made that argument for the 9 years I've been in the legislature. So when you said that, you validated me. Thank you. And I just can't let all these people leave today without knowing that happened yesterday, and an opportunity to move toward better policy is literally at their fingertips, and they've been given a new opportunity. So thank you.
I just want to comment on that real quick. That's a great point. And Dr. Eiton, when he began working at the California Endowment and handing out millions of dollars to do community equity, health, social determinants of health work, the first projects he wanted to pay for were political empowerment projects. They were projects to do voter registration, build community alliances, and he said, we're not going to get anywhere unless these communities have power. And if you think back to the map I showed you, policies are at the beginning, and you shape policy by shaping power. And the communities that have been disenfranchised have low levels of power, they get ignored, and then they've internalized that oppression by being alienated. If you look at interviews after the election in 2016, a lot of people of color didn't vote, and they said it doesn't matter. You know, we elected an African-American president, and I'm still poor. We have to change that mindset. We have to make it matter. We have to show people that if you participate, the power structure will listen to you, they will bend to your will, and you will get what you need. So yes, thank you. That's a great point.
Let's thank Dr. Kaplan for a great. Thank you so much. That was really wonderful. Okay, so we're going to move the program forward a little bit, and we're going to look at our workbooks again. So if you could just refocus. And while we get our workbooks out, I just want to again encourage you, if you have not downloaded the YAP app, that all the presentations, Dr. Kaplan's presentation is on there. If you need Wi-Fi connectivity, just go on to Thomas Jefferson, it'll say guest, and just click on that one. You don't need a password. So I encourage you, thank you for sharing that as well. All right, so we're still on page 10, and what we're going to do now is we're going to be using that middle column. So, in thinking about the strategies that Dr. Kaplan, shared with us, highlighted in his presentation, in what way does your organization carry out these strategies? He provided us with 10 strategies. In what way does your organization carry out these strategies? And what strengths does your organization already have around these strategies?